Hello, everyone. Welcome to the Derm Club podcast. Today, I have Dr. Anthony Mancini with me, and we are going to talk about some very interesting topics. First, I just want to start off by talking about infantile hemangiomas. Infantile hemangiomas occur in about 1 in every 20 infants across all racial groups. For many new parents, if their child is born with one or develops one soon after birth, it can be very scary. My own cousin's little baby girl had an infantile hemangioma when she was born. I saw firsthand the worry that the parents had. This is a very important topic for pediatricians and dermatologists who treat newborns to learn how to better manage infantile hemangiomas when you do see them. And for those patients who are listening today, rest assured, we have one of the most prominent pediatric dermatologists here today on the Derm Club podcast to discuss his expertise on managing and treating infantile hemangiomas. My guest today is Dr. Anthony Mancini, a professor of pediatrics and dermatology at Northwestern University Feinberg School of Medicine and head of the Division of Pediatric Dermatology at Ann and Robert Lurie Children's Hospital of Chicago, where he directs the division's Pediatric Dermatology Fellowship Training Program. Dr. Mancini is a co-author of Hurwitz Clinical Pediatric Dermatology, co-editor of the AAP publication Pediatric Dermatology, a quick reference guide, and pediatric section editor of Dermatology. To top it off, Dr. Mancini was also the past president of the Society for Pediatric Dermatology and past program chair of the World Congress of Pediatric Dermatology. Wow, Dr. Mancini, you have a lot of things I listed here. So it's such a pleasure to welcome you and to chat with you today.
Thank you, Hannah. It's a pleasure to be here.
Thank you. Let's start off by just very basic for our audience. How common are infantile hemangiomas?
Well, they're really common. Really depends on which data you look at, but in the literature, the incidence has ranged from about 2 to 12% of infants. Most hemangioma experts would give you a number right around 4 to 5% of all infants will have an infantile hemangioma.
Do we know why it's more common in females?
We actually don't really understand that all too well, but they do appear to be more common in females. Remember that is primarily gleaned from data that was based on premature infants, where females outnumber males about 3 to 1. But even in term infants, it is believed that hemangiomas predominate in females.
So how often do you see in a premature baby, will you see an infantile hemangioma? I know, for instance, my cousin had a preemie, and she did, in fact, have an infantile hemangioma. I do recall, though, when they brought the baby home from the hospital after delivery, they thought she just had like this little red mark on her face, that maybe she scratched her face. And then I actually took notice of it very early on, and it slowly began to grow, and it was in an unfortunate spot on her face. So I'm just curious how often you're seeing it in babies that are premature.
Yeah, we see it quite frequently. I mean, those of us who are hemangioma specialists and get a lot of these referrals see hemangiomas in the entire spectrum of neonates, but they are not at all uncommon in premature infants. And remember that they're also more common in babies of multiple gestation pregnancies, in which case both babies or all 3 babies, if there's triplets, may have a hemangioma, but there may be discordance as well. It's not unusual that we'll see one of twins has the hemangioma, one does not.
Besides the risk factors that you mentioned, which is being a premature or multiple gestations, which is multiple pregnancies, what other risk factors are involved for developing an infantile hemangioma?
Yeah, so there's many out there, and this is really an evolving field. There's a lot of newer publications coming up. In fact, I just reviewed a very large study last week that'll be accepted for publication, looking at risk factors, and some of them may change the classic paradigm. But classically, we think about things like being white race. It is far less common to see infantile hemangiomas in babies with skin of color, African, Asian descent babies, although we still see them there as well. But definitely white children seem to have the most frequent incidence of hemangiomas. I mentioned multiple gestation, a study we did in twins several years back. I'm part of a large multidisciplinary hemangioma investigator group. And a study that we had done looked at twins, and we looked at whether discordance or concordance for having a hemangioma among the twins was related to monozygosity or dizygosity. And it turned out that there really was no significant signal seen. So whether it was a monozygotic identical twin or dizygotic fraternal twins, it didn't really have a significant impact with respect to concordance for both having a hemangioma or both not having hemangiomas. Other risk factors: advanced maternal age, placental abnormalities, most specifically placenta previa is one that's been identified as being a real risk factor for infantile hemangiomas. And then maternal factors such as mothers who experience preeclampsia and hypertension during pregnancy, those are risk factors as well.
So I have a question. Is there any genetic relationship that we understand at the moment? Like if the mother had an infantile hemangioma when she was born, which she may not even remember because at this point it's probably already faded, and probably hasn't left a scar. Is there any genetic predisposition that her child will also have it?
So we have not identified any clear-cut genetic cause for infantile hemangioma. So mom having a hemangioma doesn't necessarily place her baby at risk. However, it's not unusual in one family or a woman who's had multiple children to have more than one that has hemangiomas. But that is probably more likely to relate to these risk factors that are shared with that woman. For instance, her age at the time of delivery, being prone to premature delivery, hypertension, et cetera, the things that I've just mentioned. But we don't, as of this point in time, have a clear-cut genetic etiology.
Do we understand at this point what the cause or the pathophysiology of an infantile hemangioma is?
No, and there are others that really study this in detail, both clinically and in the laboratory. I will tell you that just to kind of summarize this, there's a few different hypotheses. One of the leading hypotheses suggests that there are circulating endothelial progenitor cells and that they migrate to conditions that are favorable for the onset of a hemangioma, such as areas of hypoxia or perhaps a region where there's a developmental field defect of some sort. Another theory really thinks more about the placenta, placental endothelial cells, placental tissues. And this is the fact that the endothelial cells within hemangiomas stain positively for something called the erythrocyte type glucose transporter. Any physicians listening will know that that's also known as GLUT1. And GLUT1 specifically stains these endothelial cells in hemangiomas, but also stains other microvascular endothelial cells within blood tissue barriers, so brain, placental tissue. In fact, placenta and hemangiomas, their endothelial cells share multiple markers that will stain positively. So this theory suggests that perhaps these hemangiomas come from angioblasts that differentiate towards that placental phenotype and become what we know as an infantile hemangioma. There are also more recent research has shown that there may be some relationship to the Renin-Angiotensin system. And this is interesting because when you have research that can lead to a bench to bedside translation, this has resulted in some early studies now looking at other therapeutics, such as angiotensin converting enzyme inhibitors, ACE inhibitors, as a potential treatment for hemangiomas. So still much to learn about pathogenesis of these lesions. And I think as more is discovered, this will lead to newer potential pathways of treatments.
Very interesting. So I understand that infantile hemangiomas are divided into like a timeline per se. First, you have the proliferation phase, and then it goes into this like involution phase where you start to see it kind of shrink and change in color and fade eventually. Can you discuss that timeline with us? I know every patient, of course, varies. So you might see some patients that this timeline happens much faster than others.
Of course, and patients never read the textbooks, as I say to trainees. So, but this is fairly characteristic, and it's characteristic enough that this is one aspect we teach trainees, really helps you distinguish hemangiomas, the most common vascular lesion we see by far in a pediatric dermatology clinic, from a whole other group we call vascular malformations, which are static lesions that are often present at birth and remain relatively steady throughout the life cycle, except for mild increases in size with age of the baby. Hemangiomas, on the other hand, are typically not present at birth, although there can be some precursors we'll talk about. They have their onset between 2 and 4 weeks of life is when they often become noticed. As you alluded to in your family member, often it's thought the baby has a little scratch or there was trauma from the delivery, and then people realize, wait a minute, this is getting larger, it's turning into something, it's not just a scratch or some trauma. They then enter what's called the proliferative phase, and this is the active phase of growth of hemangiomas. The proliferative phase can last upwards of 9 to 12 months, but we now know from some really nice recent studies that most of the growth, this proliferative phase, is completed by around 5 to 6 months of life. So one thing I can say to many parents now is that we know that roughly 85% of growth of that hemangioma is done by 5 months of life.
Mhm.
And this is really important when you see a baby and you're considering therapeutic options, you're considering prognosis and potential medical complications of the hemangioma, knowing the patient's age and what you see at that point in time. And some of this newer data really will help you in making the determination whether treatment is necessary. Now, often the hemangiomas will grow for a while in that proliferative phase and then enter what used to be called the plateau phase, where there's not much change. But now we kind of really consider either proliferation or involution. And involution refers to when hemangiomas begin to go away, and this often happens spontaneously on their own. It classically starts some point after the first birthday, although we see some babies where this involution phase begins earlier, and other lesions like deep hemangiomas, which may not start their involution phase until later.
Mm.
Really important to think about involution, and for parents to know that that whole process is very gradual, and it could take upwards of 3 to 6 years for it to be complete. So I always tell a parent that we won't know until 5 or 6 years what the final outcome will be. That doesn't mean we always wait until that point in time to make decisions about treatment. We have to be able to look into our crystal ball based on our experience and what we know about hemangiomas and decide if a baby needs treatment early in life, because as we'll talk about when we talk about therapy, our treatments are directed towards hemangiomas that are in that proliferative phase. They don't really work in those that are in the involution phase. One other thing I'll add, Hannah, before you go on to the next question is, we talked about the proliferative phase. The growth rate is different at different points in that period. So we're talking about the first 5 or 6 months of life here. They don't just grow on a steady incline with a consistent slope. We now know from a wonderful study that was done based on parental photographs, every new parent of a baby takes pictures on a daily basis. So a few of our colleagues decided, well, let's collect these photographs and we'll have snapshots throughout the first several months of life. And they decided to then rate the hemangiomas, their features, their growth, and could tell from those pictures and the study of many of these babies when the most rapid growth occurs. And we now know that that most rapid growth is between about 5 and 8 weeks of postnatal age. And it's interesting, once this study came out, and I began discussing this with patients in the clinic, parents often will say, yeah, and we thought between 1 and 2 months this thing was taking off, but now that she's 3, 4 months old, we feel like it's kind of slowed down again. So it really has borne out in clinical practice.
So it sounds like it's very important for the parent, if they want to have it treated, to come in like basically as soon as they notice it, because the earlier the intervention, the better outcomes.
Well, that is true to a point. We really are trying to teach our primary care colleagues about the value and the importance of early referral for hemangiomas that might merit therapy. Remember, there are some hemangiomas which are totally appropriately managed by the pediatrician. A case in point would be a 1 centimeter hemangioma on the back of a newborn that's not bleeding. There's no need they have to rush in and refer that baby. But as we'll talk about, we have a risk stratification now. Lesions that fall into certain categories of highest or high risk really should be referred within 1 to 2 weeks to a hemangioma specialist, and we'll come to that a little bit later.
Okay, great. So can you talk about what the various morphologic types of infantile hemangiomas that exist?
Absolutely, that's important because we now know that the morphologic features help us decide how risky that lesion is, what kind of complications we may see, how worried we have to be. So first off, hemangiomas can be broken down into superficial, deep, or mixed type. Let's go through each of those. A superficial hemangioma has the majority of its growth on top of the skin surface. These are the classic bright red lesions that used to be called strawberry marks or strawberry hemangiomas. We no longer use that terminology. Deep hemangiomas, on the other hand, if this is the skin surface, the majority of growth is below the skin. These tend to present as nodules, compressible nodules that have a bluish hue, and they often will present later, grow on a more delayed timeline, and may take longer to go away. And then if you mix those two together, growing on top of the skin and below the skin, we have what's called a combined or mixed hemangioma, and that's probably the most common type that we see. They have components of both, so you really have to consider all of the different aspects of superficial and deep hemangiomas when you evaluate those babies. So that's looking at the specific hemangioma growth. We also look at the growth morphology of the lesion, and this is where we call lesions localized, segmental, or multifocal. Localized lesions, they look like they've risen from a single focal point. So these tend to be round, although not always perfectly round, and they grow in one area. Remember that hemangiomas map themselves out very early in life. Growth beyond the neonatal period is really volumetric. And what I mean by that is if you see a patient come in at 6 weeks of life with a hemangioma that's 3 centimeters in size, this parent has gone on the internet and they've seen patients with nightmare lesions, right? The giant hemangiomas on the face, and they're worried their baby's lesion is going to turn into that. And we can really reassure them that the hemangioma is already mapped out. That lesion might grow outwards from the skin or a little deeper into the skin and maybe get a tad larger, but it's not going to become a lesion that's 4 times its size. Growth is volumetric after the neonatal phase. So those are localized lesions. Segmental hemangiomas, on the other hand, are very different. These are lesions that grow over a much wider surface area. They often have bizarre configurations and borders. They're linked somehow to developmental metameres, units of growth within the skin. And these are the lesions that are a little more worrisome because they're more likely to be associated with extracutaneous involvement. That means involvement elsewhere than the skin. Also may be more likely to be associated with a variety of syndrome presentations and be more complicated. They may ulcerate, they may grow more rapidly, they may bleed. So segmental hemangiomas, we really think should be referred most of the time to a hemangioma specialist, whereas localized hemangiomas, we'll talk about when we get to the risk stratification. In certain locations, they all merit referral, but in other locations, they actually may not. And then I mentioned multifocal. Sorry, Hannah, did you have a question?
I just wanted to ask you, is there a specific location on the body that the infantile hemangiomas like to pop up in? Like, are they more likely to pop up on your extremities or your face?
That's a good question. I mean, bottom line is a hemangioma can occur anywhere you have skin or mucosa. We see hemangiomas in the mouth as well, right? But they do tend to favor neck up. We see a lot of facial, neck, and scalp hemangiomas in babies, but really they can occur anywhere. Let me get back to the multifocal hemangioma, also called multiple hemangiomas. Now, what is this? This is a baby who has more than one hemangioma, literally defined. Multifocal hemangiomas are important because they can be a marker for involvement in other organs, most commonly the liver. We now know that the magical number seems to be 5 or more skin hemangiomas, where we have to worry more about liver involvement. We did a study several years back where we prospectively enrolled babies with multiple hemangiomas, and we compared those with 5 or more to those with 4 or fewer, and we did ultrasonography of the abdomen on all of them. And we did that because it had always been taught, 5 or more, you worry, but nobody knew where that came from. So we decided to use that as our beginning, our dividing line. And that study actually confirmed, as did a recent, much more recent study, that 5 was the magical number. And it seemed that 5 or more put you into a much higher risk group for liver hemangiomas than did 1, 2, 3, or 4 lesions. Liver hemangiomas are an entirely different beast. They come in several different morphologies, but they're important because they can cause hypothyroidism, they can cause abdominal compartment syndrome, and can cause high output congestive heart failure if they're very extensive and there's very large flow in them. So those lesions at times will need treatment, although the majority of them don't need to be treated.
It sounds like the same threshold for neurofibromas, or if you have a certain amount, it starts to get concerning.
Yeah, although with neurofibromatosis, we're basing that more on the cafe au lait lesions, right, than the actual neurofibromas. But yeah,
yes,
kind of a similar situation.
So what features are the most concerning, especially when if you have a patient that walks into your clinic and you either like right away, you can say, this is not to worry, you're going to be fine. Give it 5 months, a year, it'll be gone. Or when you have those patients, you say, this is a little bit trickier.
So this is really where risk stratification comes in, and that's what you're asking. And I want to just highlight for the listeners that we did publish a clinical practice guideline on infantile hemangiomas. This was published in the journal Pediatrics in 2019. And in that paper, there's a supplemental paper that you can access online, and you can access these without any sort of subscriptions. The supplemental paper is really important because that contains a table on risk stratification. And risk stratification is very important, especially for our primary care colleagues, but also for dermatologists who may not be hemangioma specialists, but see these children, or for other pediatric specialists or practitioners. So the risk stratification is broken down into 4 categories: highest risk, high risk, intermediate risk, and low risk. And these risk categories then in another figure we have in that supplemental paper so tell you when the baby should be referred. I mean, this is idealistic. We realize there's many factors that go into referral, including geographically. Some people just don't have access to pediatric dermatology or other hemangioma specialists, or it may take much longer. But ideally, we tell when that baby should be referred. So highest risk lesions, referral is recommended within 1 week. High risk lesions within about 2 weeks. And then intermediate and low risk lesions, it really depends. The low risk almost never require referral. Intermediate may or may not, really depends on the baby's age and the evolution of the lesion. So what are the highest risks? That's the most important place to start. Who are these babies that if you see they need to be referred, or if you're a parent and your baby has one of these, they need to get into a hemangioma specialist ASAP? That would be 4 primary categories. A large facial hemangioma. So these are those larger segmental hemangiomas I talked about. They often are 4 or 5 centimeters or greater. Those merit immediate referral. Similar large segmental hemangiomas, but in the anogenital region. So anything on the genitals, the perineum, the perianal area, even the lower back. We know those lesions are at higher risk for complication, but also at higher risk for having syndrome associations. They really need evaluations of other organs. Then there's going to be anything that's periorbital. Periorbital lesions tend to be very common for hemangiomas. And by periorbital, for the lay people who are listening, that's around the eye, eyelids especially. Now, forehead is not really truly periorbital, but if it's below the orbital ridge, below the eyebrow, near the upper eyelid, those are all very important lesions, as they can lead to a variety of complications we'll talk about. And then the 4th category would be babies with the multifocal lesions. And in the clinical practice guideline, we recommended 5 or more based on the studies that we have to date. Really, those would merit more immediate referral. Or if you can't refer, the primary care doctor could at least get that liver ultrasound going immediately. Now, instead of going into high risk, I'm going to jump down to intermediate and low risk, because high risk is a large category that kind of includes everything else I don't mention. Low risk lesions. These are small hemangiomas on the trunk. I mentioned earlier, having a 1 centimeter lesion on the back in a 3-month-old. That's the kind of baby that, of course, can be followed by the primary care provider. Or even larger lesions on the trunk or extremities, as long as they have smoothly sloping borders. And by that, I mean a lesion where the borders go up smoothly, not they stand out from the skin at 90-degree angles. And that's because those that really stick right out are more likely to leave behind extra tissue after the hemangioma has gone away. We call fibrofatty tissue, which will often require surgery. So that goes into the intermediate group. But if it has that smooth border, that's still in the low group. The other category in the intermediate group is perineal lesions, small hemangiomas, not big segmental ones. But let's say you have the pencil eraser size lesion on the labia of a 2-month-old baby girl. If it's not ulcerating, not bleeding, and most of its growth is done, that probably can be followed by the primary care physician. But if it seems to be growing at a hefty rate, or the baby's really young, especially under a month, we probably would refer those babies, because we know lesions under the diaper area are more prone to ulceration. And then there's that high risk category, which was the second most urgent, and it covers many categories. I'm not going to go over all of them now. I refer the listeners to the paper, again, the clinical practice guideline in pediatrics in 2019, and the supplemental paper, which has this table. It's very easy to follow.
So my cousin had her baby had a infantile hemangioma in the glabella area, kind of lining her eyebrow, growing towards her eyelid. And I think as it was starting to approach 5 centimeters, so she proceeded to have it surgically removed after doing a trial of beta blockers and other options. They decided to eventually surgically remove it.
Well, we're going to come to surgery a bit later, but let's just talk briefly about some of these concerning locations. So periorbital I mentioned, and that's because these lesions can lead to things like stigmatism. You can get visual axis obstruction, so the baby doesn't develop vision. If the eyelid's closed especially, they won't develop normal binocular vision. Nasal tip lesions, we really want those babies referred really quickly, because they can permanently deform the cartilage in the distal nose and the nasal tip, and that really requires surgery, and it's not easy surgery. Lip lesions, because they tend to ulcerate. They can interfere with feeding. If they ulcerate, they're very painful. They're going to scar. They can get infected and they bleed. And they also will permanently damage the lip, and that's very hard to ever repair. Philtrum, this part of our upper lip, those lesions, especially if they're more than a tiny ditzel, really important to refer those babies quickly. And that's because these bigger, deep lesions in that area distort what we call Cupid's bow. That's that normal anatomic feature we have there. Very tough to ever get that back. Ear lesions. can deform the ear permanently. Larger ones over the canal can actually interfere with the development of hearing. So those merit quick referral. So that's just a feel for some of these categories where we really want those babies referred promptly.
Thank you for that. Why do some lesions shrink spontaneously on their own without treatment? I know we have this involution phase, but do we understand the pathophysiology behind why they are able to spontaneously shrink at times and some are not?
It's very interesting. We don't understand. This was actually one of the topics of my research as a fellow before I even started dermatology training. We looked at a bunch of hemangiomas that were in proliferative versus involution phases, or that fibrofatty tissue left over. And we stained with stains for apoptosis, which is programmed cellular death, where cells on their own die and resolve. And we found that there was marked increase in apoptosis in involuting and involuted hemangiomas. They stain more with things like BCL2, which is a marker for apoptosis. And many other studies have shown that. But why that programmed cellular death occurs and why does it start at the point of 1 year is really unclear. There's some newer studies that look at why is there increased fat in hemangiomas. So there are changes that are happening that biochemically increase fat cells in some of these lesions, accounting for the fibrofatty tissue, but still a lot to learn there.
Fascinating. Can you talk to us a little bit about face syndrome and how you approach a patient who has this?
Yeah, so face syndrome, again, for those who aren't familiar who are listening, that's a mnemonic. Each one of those letters in PHACES, it's faces, stands for something. But really, it's the classic combination of large facial hemangiomas, although now we know they can also be scalp, they can be neck, they can be upper chest, with higher risk for abnormalities in the brain, the arteries in the brain and the neck, the heart, and the eyes. So really need to do a very extensive evaluation in these babies. They can also have hearing anomalies. They can have thyroid abnormalities. And these are lesions that tend to be a little more complex and complicated. The equivalent of this, I mentioned earlier, is a giant lesion down in the lumbosacral back or in the perineum or the genitals, and that's something called pelvis or lumbar syndrome. And again, those are mnemonics, but that combines large hemangiomas in those regions with increased risk of abnormalities, anomalies in the genital urinary and gastrointestinal tracts, as well as the spinal cord. They're at increased risk for things like tethering of the spinal cord. So these babies are babies that always require multidisciplinary care, and you really have to know your local hemangioma specialist to get these babies in early.
So we spoke a little bit about early referral and why it's important. Does it show to be more promising when you have early intervention and the outcomes seem to be a bit better?
Absolutely. You talk to any hemangioma specialist, early intervention to decrease growth or stop growth of the hemangioma is always going to be beneficial, especially in areas that are prone to permanent deformity or to medical complication. So periorbital hemangioma, we want to treat that medically early in life to preserve vision. But by the same token, a 3-centimeter large hemangioma on the mid-forehead, you can say, well, that's not causing any medical problem. And there are parents of babies with lesions like that who have been told by their primary care doctors, well, these do go away. Well, that is true. But do you want your child to reach the age of 3 or 4 years when they begin to understand comments from other kids, from other adults, from the public, and it begins to impact their self-esteem and their psychosocial health? And they likewise can be left, even though the hemangioma involutes, with a big fibrofatty mass that's going to have to be removed surgically and will leave permanent surgical scarring. I'm not saying that every patient with one of those lesions will have the perfect outcome with early medical therapy, but we put them in a much better position to have a good outcomes and to minimize the need for intervention down the road.
So refer early if you think you can't handle this on your own or treat it, or if it's beyond your scope is the takeaway.
Yes, and if you think they fall into a highest or high risk category, once you've reviewed the clinical practice guidelines, those are babies that need to be referred early.
Those guidelines are key. Let's go over the treatment options that are out there at the moment.
So I like to I'm a lumper, not a splitter. So let's lump treatments into beta blockers, which are now the standard of care worldwide, gold standard medical therapy. Steroids, which were the past standard of care before it was discovered that beta blockers worked in 2008, and they were approved by the FDA in 2012. Steroids were what we used up until that point. We rarely use those anymore, but occasionally they're used. And then people always ask about surgery and laser therapy. Now, there's some other treatments, and we'll talk about topical timolol a little bit later, but those are the big four categories. So beta blockers is where we'll spend most of our time. Steroids, suffice it to say, it's a dated therapy now. I still believe steroids have a role, and there are several hemangioma specialists who still use them. I am one of them who uses them for ulcerated hemangiomas, where I think they really help healing ulcerated lesions quickly. But many of my colleagues who are other hemangioma specialists and researchers really believe that beta blockers are just as effective. So there is some difference of opinion out there. But I don't use steroids otherwise very often anymore. And I didn't mention intralesional injection of steroids, which was an old therapy we used a lot, especially for localized lesions. For instance, a lip hemangioma, but that is still used by some hemangioma specialists and can be very useful. Let's talk about surgery and laser briefly, and then we'll go into propranolol. Does that sound good, Hannah?
Of course.
So surgery is a modality that we hope to minimize with hemangiomas. Why? Surgery always results in a scar, but surgery does play a role in certain babies. The classic examples would include the child who has that involuted hemangioma, but it left behind this fibrofatty mass that we've alluded to several times. That's where surgery really plays a role. And then there are some instances where early in life, if they're absolutely resistant to medical therapy, I think you mentioned that your family member didn't respond to beta blocker therapy and had to have excision. That'd be one time where you would consider surgery as an option. Or you may have certain hemangiomas that are bleeding recurrently and it's hard to control. Or they're really ripe for a surgical treatment, such as a large hemangioma on the back of an earlobe that has a narrowed pedicle, a narrowed base, can be easily served by surgery and with a scar in an area that's going to be acceptable. So that's kind of the settings in which we consider surgery in this day and age.
What's the average amount of time that you would keep someone on propranolol before starting or considering surgery?
Well, remember, propranolol we use during the proliferative phase. We're trying to stop growth and speed up healing, but we're not going to be on propranolol until we get to the end of the road. So we usually keep babies on propranolol till shortly past their first birthday. Most of us are treating now to about 14 to 15 months of age. But that's not when you jump right to surgery, because we still have several years of spontaneous further improvement. And then it's usually between that 3 to 5 year window where you might decide that surgery is an option. And that's a beautiful window also for surgery if you have a sequela of a hemangioma, because of two reasons. Number one, it's when the risks of anesthesia precipitously drop. We now know that with the concern about cognitive development in babies who receive repeat rounds of anesthesia, 3 years is kind of our goal to not use it under that age, if not absolutely necessary. And also because that's that psychosocial development phase that's so important. 3 to 5 years is that window when they're going to begin to understand comments and questions. So intervening around that time is really optimal. Let me just touch base on laser quickly, and then we can go back to the beta blockers. Laser, we're talking about the pulse dye laser primarily when we talk about hemangiomas. In my practice, this plays a role primarily for hemangiomas that have involuted. They flattened out, but they left behind some of the surface telangiectasias, those fine blood vessels you can see on the surface. Laser is great for that. We also use laser for ulcerated hemangiomas, which seems counterintuitive. You're doing a treatment with light energy applied right to this open ulcer, but it really helps these reepithelialize, which means to heal, to have the cells grow over those open ulcerated regions. Now, there's a small handful of hemangioma specialists, handful or two around the country, that actually advocate for using laser early in life with hemangiomas that are really flat. I personally don't recommend that. Many of us have had experiences where laser can actually cause or exacerbate ulceration, but those who do it actually state that it can be very effective if the right lesions are chosen appropriately. So I think we'll leave laser at that, and then maybe we can discuss a bit about propranolol and beta blockers.
Please, and then we can go on to timolol.
Yeah, so beta blockers, I'm going to summarize this in a few minutes. Beta blockers are primarily a drug category that is used for cardiac indications, especially for hypertension, high blood pressure, also for heart arrhythmias. They've also been used for a variety of other uses like anxiety and migraines. In 2008, it was accidentally observed by very astute clinicians in France that they helped hemangiomas in babies who had been hospitalized with giant hemangiomas, but were getting the beta blocker for a heart issue. So after they noticed that, they prospectively started a few more patients on the drug and realized, wow, this actually helps hemangiomas. Then we fast forward, within a few years, there was a multi-center, multidisciplinary, collaborative prospective research trial that was randomized and placebo-controlled, performed by a drug company out of Europe. At the end of that study, it was shown that propranolol was far, far more efficacious than placebo in treating hemangiomas. The randomization was changed because it was discovered we had to be really ethical. And so we really increased the numbers of patients who got propranolol in that study once the signals began to be seen that it was really so beneficial. And in 2012, it was approved by the European Medicines Agency as well as the United States Food and Drug Administration. So we've been using it since 2008, but it was off-label. 2012, we got approval and have an FDA approved formulation of propranolol, and it's now become the standard of care. It's a great treatment because it does two things. It slows or stops growth of hemangiomas. Almost every baby will have some benefit of propranolol, and it speeds up the healing. So I tell parents, if we chose not to treat this lesion on your baby, and at 5 years of age, this is how it's going to look, on propranolol, we'll probably get there by 2, 2.5, or 3 years. So it speeds everything up. And if you slow down growth early, remember, you also are going to have better outcomes because you have less hemangioma to go away. It's given orally by mouth. And I think we should just address some of the key side effect issues we see with propranolol so people have a good understanding of just how safe this drug is. So first off, people think, well, it's a heart drug. Is this going to damage my baby's heart? And the truth is, in the baby with a healthy heart and no evidence of arrhythmia, either family history or personal history, if they do have that, we have to get a baseline EKG. But if not, it started as an outpatient, and it's actually really well tolerated. And although it does lower heart rate and blood pressure by a few drops here and there, it's really largely clinically asymptomatic. Babies don't notice it. Babies with healthy hearts don't notice the cardiac effects, for the most part, of propranolol. So really, it's 3 other side effects that we counsel about and spend more time on. The first is low blood sugar. It doesn't cause low blood sugar, but it can inhibit some of the body's normal mechanisms to counteract low blood sugar. Hence, if a baby's sugar drops, like it might do in the baby who starts to sleep 12 hours a night and they haven't eaten all night, by 8, 9 hours, your blood sugar starts to drop. Propranolol could make that worse and really could lead to serious hypoglycemia. So we can prevent that by teaching all parents that babies have to eat before they get their dose. If they don't eat, they don't get their propranolol. It's that simple. I usually tell families they have to eat at least half of their normal volume, whether formula or solids, before they get their medication. We also don't want babies getting a dose with no food and then going without eating longer than 6 to 8 hours. And that's because of what I just said. By following those guidelines and educating our parents, the number of cases we've had in our center where we treat thousands of babies with hemangioma of hypoglycemia have been 0. You just don't see it if you counsel appropriately and give parents appropriate warnings. The second is bronchospasm. That's twitchy airways. So think of that as what happens in asthma patients, right? And they get wheezy, they breathe more rapidly, they may have shortness of breath, their chest is tight. It's known that beta blockers can make bronchospasm worse. In fact, beta blockers as a class are contraindicated in patients with asthma. So we warn families because when babies get upper respiratory infections, what happens? They get twitchy airways, they get bronchospasm. It's common in normal babies. So we tell families that if your baby gets sick, as long as he or she is eating and breathing okay, and if they're getting bronchospasm, parents are going to note coughing, difficulty with feeds, breathing rapidly, they might see retractions, they might hear wheezing. Any of those, they hold their propranolol and they go to their pediatrician or to an emergency room. So those are the big 2. They're both very uncommon now that we counsel appropriately, but the most common side effect by numbers is nightmares or night terrors. And those are known to occur in upwards of 10 to 15% of babies who receive propranolol for hemangiomas. I always tell parents that means 1 in 7 get them, but that means 6 in 7 do not get them. I feel we saw more back when we were dosing this in the early years 3 times a day, which meant babies got a dose in the evening. I feel we saw more night terrors than we see now. I now teach parents to dose early morning and early afternoon, and we just don't see them nearly as often. But those are the risks in a nutshell. Overall, a very safe drug. And as we mentioned earlier, we like to treat till about 14 to 15 months, because if we stop too early, even the hemangioma that looks great, if we stop it at 7 months of life, that hemangioma will come back. And sometimes they come back with a vengeance. We call that rebound growth. We don't understand it too well, but we have found the best way to minimize its risk is to keep treatment going until 14 to 15 months.
Very interesting. I sometimes have mothers or fathers come in or parents who say, "Oh, I forgot to give my child a dose the last 2 days. Like, should I be concerned? Is what's going to happen? Is this concerning at all if you skip a dose and you forget occasionally?"
It's a great question, Hannah, and it really depends on the baby's age. Okay, so if it's the 2-month-old that has an eye closed and they start propranolol and that eye starts to open, and they miss 2 days, they're going to notice the eye close again, probably. Those hemangiomas really regrow quickly. But the baby who's 3, 4, 5 months into propranolol therapy, hemangioma is doing great. It's been pretty stable for several months. Missing a dose here or there, they're not going to see much of anything. It's also, I reassure parents, it's unlike steroids. When we use steroids back in the old days, if you miss a dose of steroids, that can be very dangerous, right? Because of adrenal suppression, your adrenal glands stop making what they need to make because you have the exogenous steroid. With propranolol, there's no such risk. There is a risk of tachycardia. So if you stop a beta blocker immediately, because beta blockers lower heart rates with their beta blockade, you can get this rebound sinus tachycardia, which for the lay people just means rapid heart rate, which can make any of us feel kind of crumpy or anxious. So that's one reason we tell parents to taper propranolol also, is just to prevent that sinus tachycardia. But missing a dose here or there is often not an issue.
What is your opinion on topical timolol, and do you use it in your clinic?
Yes, so timolol has been a really useful addition to our armamentarium for the right hemangioma. So timolol is in the same category. It's a beta blocker. It's a beta blocker that in an eye drop is used for glaucoma. So it's used to combat increased pressure in the eye, and it's used in pediatric patients as well. Once propranolol became such a standard of care, some astute clinicians said, well, maybe for these smaller hemangiomas, timolol would work topically, and we could prevent the baby from having these side effect risks of an oral beta blocker. It turns out for the correctly selected hemangioma, timolol can be very beneficial at slowing the growth, and again, sometimes speeding up the healing. But it's really vital that you select the correct hemangioma. We get this question a lot from pediatricians who send their patients to us and they say, could I have just done this? And I teach them, as long as you read a little bit and are comfortable knowing when you can use it. So timolol is most effective for hemangiomas that are no larger than 1 to 1.5 centimeters and are flat. Not these big dome-shaped lesions, not large tumors. They will do nothing there because they can't penetrate deeply enough. And in fact, we now know with greater blood flow through the larger hemangiomas, there is probably more uptake into the systemic circulation, and timolol is a much more potent beta blocker than propranolol, so it can actually be dangerous. If you have a premature baby with a big deep hemangioma and the mom's putting timolol on there 3 or 4 times a day, that baby could get systemic timolol levels that could have toxicity. So select the lesions carefully. They have to be, I said, 1 to 1.5 centimeters or smaller, flatter lesions, and don't select lesions that are compromising a vital function. So you use this. A classic example is the small lesion on the forehead. The parent wants to do something, but even I as a clinician feel like, gosh, propranolol is a big gun for that lesion. Timolol is perfect in that instance. We have them apply 1 drop 2 or 3 times a day, and the duration of treatment really depends on the lesion and the patient.
When it comes to surgery, I know we touched upon this already. Do you warn the patient, sometimes, of course, if it's going to be excised, you can have a scar after the fact. And are there any chances of having a re-evolution or a rebound of the hemangioma after it's been excised?
So I highlighted when I would recommend surgery, which is the vast minority of cases of babies I see with hemangiomas. But if they have that fibrofatty residua or they have a lesion that just needs to be excised because it's bleeding, of course, we're going to have that discussion about surgery always leaves a scar, and it will be a permanent scar. How that scar looks largely depends on the surgical site, the technique used, but also the wound care that happens after the surgery. It's very hard to keep young kids still, but infants a little easier than toddlers, clearly. And so as far as recurrence of hemangiomas after surgery, that's not something we typically see. So usually, again, because of the subset we're selecting for surgical treatments, it's a setting where you would not expect rebound growth of the hemangioma.
It sounds like education and reassurance to the parents and to the child are so important, because both parties can, undergo psychosocial consequences. Is there any advice you give parents? Like it sounds like you really have to be patient. This could be like a few years. It could be a short time, but it can also take 4 or 5 years until it's fully gone. Um, do you have any advice to parents or even physicians in counseling their patients?
Yeah, I think it's really important. A lot of parents have to hear that they did nothing wrong. They didn't cause this hemangioma. And despite the fact that we review some risk factors that the mother may have, this is not a guilt situation. Hemangiomas are extremely common. Much about them is unknown, and they should not internalize any responsibility for the baby having a hemangioma. I also reassure them that one thing parents worry about is that their baby's going to bleed to death from their hemangioma. They worry if a little bang happens or the baby catches their nail and nicks it and it starts to bleed, that there's going to be this exsanguination of blood through the lesion. And I explained to them, it's not a big pocket of blood. It's a bunch of cells, and there are increased blood vessels, and bleeding will be more brisk than skin doesn't have a hemangioma, but your baby is not going to bleed to death. Uncontrollable bleeding is extremely rare. All of us who are hemangioma specialists have seen a handful or two of these babies, but that's because we get all the referrals, but it's very, very rare. And then lastly, I tell families that we're in a much better place than we were. When I was in training 25 years ago, all we had was steroids or nothing. That's what we did. A laser was in its infancy. So we put these babies on oral prednisolone for up to a year, sometimes longer. We stunted growth. They got hypertension. They got horrible gastritis and reflux. And they got immunosuppressed, quite frankly. But it was all we had. They worked, but there were a lot of side effects. I reassure that now we have this drug that is so much safer. It's better tolerated. And when we take the time to educate and give precautions, I never say 100%, but the vast majority of our treated babies do really well with treatment. So I really try to reassure families. I give them referrals to sites that will really help them. There's really good sites on the internet from various organizations that offer education on hemangiomas, and I'd rather them go to one of those 3 or 4 reputable sites than just plug in hemangioma into Google Images, where they're going to see the worst and be really fearful.
So it sounds like we've made great progress in this specialty and field. Where do you foresee the future of infantile hemangiomas in terms of understanding the causes of it and the future treatments that we'll have?
Yeah, so the field has really been revolutionized. It's very exciting. I love my clinic days. I tend to cluster my hemangiomas on certain days, and I love those days. I love treating this condition and helping out babies and families. Obviously, research is continuing at a really rapid pace. There are many, many more people interested now in vascular anomalies in general. Any physicians who are listening know about the International Society for the Study of Vascular Anomalies, ISFA, which has representation from all over the world now and has yearly meetings. We need to continue to educate pediatricians and primary care providers so that they feel comfortable knowing when to refer, when to worry with these lesions. We also need to better understand prognostic factors, and also like this phenomenon of rebound. We have some children that we see that have their hemangioma growing again at 2 years, 3 years. I've had 4-year-olds that I have back on propranolol. We don't understand that really at all. So it'd be really nice to have a better understanding of that. Medical therapeutics, this is in its infancy. So we talked about propranolol a lot today, but there are other beta blockers that have been looked at in certain areas in Canada. They favor nadolol over propranolol. Nadolol doesn't cross the blood-brain barrier. There's less concern about nightmares, night terrors, or cognitive development, which at one time was a concern that really hasn't borne out in the literature. Atenolol, a beta blocker that's cardioselective, so it doesn't have the associated risk of bronchospasm that we talked about with propranolol. So these other beta blockers have been looked at. There might be newer agents. I mentioned earlier ACE inhibitors. I've seen some papers on that now, and even more targeted therapies that are targeted against vascular growth factors like vascular endothelial growth factor, VEGF, or basic fibroblast growth factor, or others that we know are upregulated in these lesions. So it's going to be a very exciting time. I think along with all the diagnostic and therapeutic data that we need and further research we will have is this accentuation we have now in all areas of medicine on focusing on burden of disease, on quality of life impairments, approval by insurance companies for early referrals for treatments that we need, including laser therapy when it's indicated. And then again, probably the most important factor, Hannah, is partnering with our primary care colleagues on early referral. Nothing breaks my heart more than when I see a baby come in at 10 months of age with a giant hemangioma that has distorted or permanently destroyed an ear, for instance, that could have been treated earlier in life, but it was a simple lack of understanding or appreciation for the fact that we do have good treatments, and those treatments need to be utilized early.
Thank you so much. Is there anything else you want to add, Dr. Mancini, that we didn't touch upon today?
I think we covered a really broad spectrum. I know one thing you and I had discussed was, what about treatment for ulcerated hemangiomas? What do we do when they actually ulcerate? And so if we have a minute, I'll just mention how we approach that. We good?
Yeah, please go ahead.
So ulcerated hemangiomas, this is hemangiomas that tend to be larger or in certain locations, for instance, lip, anterior neck, the genital region, anogenital area. Those areas like to ulcerate. And when ulceration happens, it's very painful for the baby. It will lead to decreased oral intake, a decreased sleep. They can get infected, they permanently scar, and that pain really can't be underestimated. So there are a variety of useful treatments for ulceration, which range from medications to wound care to even laser therapy or surgery. Wound care is usually a combination of wound dressings, barrier products, and topical antimicrobials. We sometimes use, in an off-label fashion, a drug that's really approved for adult diabetics for leg ulcers, but we use it off-label for kids with ulcerated hemangiomas if we can get it, because it's rarely covered and very expensive. And it really can accentuate healing. That's a recombinant platelet-derived growth factor gel called Kopelman that we use sometimes. Laser therapy, I mentioned earlier, can be very helpful for ulcerated lesions. It really can help seal the surface. It's painful during the treatment, but the treatment is quick, and it really helps them reepithelialize and begin to get a layer of skin overlying the ulceration. And then systemic treatments. So steroids and beta blockers are really the primary two categories utilized here. I'm still a big fan of steroids, as I mentioned earlier. I think in this setting, with ulcerated lesions, I find that often a 4 to 8 week course of oral steroid really helps them heal more quickly. I have colleagues who go right to the propranolol. Often we do a lower dose in ulcerated lesions, because part of a mechanism of action of beta blockers is they vasoconstrict, they clamp down blood vessels. So there has been some concern that they can make ulceration worse. So we often use a lower dosing, around 1 milligram per kilogram per day, versus our more typical therapeutic 2 to 2.5 milligrams per kilogram per day we use in most babies. So that's kind of just a quick glimpse at how we might treat ulcerated hemangiomas. Pain control also, and if we get beyond things like acetaminophen and ibuprofen, then we actually get our pain specialists involved to discuss narcotic analgesia.
At what point do you decide to go from topical to systemic therapy?
The mildest ulceration, which often presents just with a little crusting on the surface, those patients I will often treat just with topical wound care, maybe even an oral antibiotic, because sometimes they get a secondary staph infection, a bacterial infection in there. But if it's a frank ulceration, typically we're going to do more than just topical wound care, either laser, short course of steroids, beta blocker therapy. Some have used timolol. I would just caution the listeners about topical timolol with ulcerated lesions, only because I do have concern about the systemic absorption through an open, raw, ulcerated surface and the potential toxicities.
It would be amazing if one day we could, give the mother, if the mother, I guess, finds out, or I guess it's hard to know, but it would be amazing if we could detect before the birth that this baby is likely to have an infantile hemangioma, and therefore we're going to treat the mother with this medication that we know will cross the placenta to avoid forming this infantile hemangioma. But I know that's very far in the future.
Yeah, hypothetically, that sounds great, but based on the life cycle of these lesions and the fact that they often don't have their onset till several weeks postnatal, this is something that is not picked up on prenatal ultrasound. And that is a question of parents sometimes. Why didn't they tell me my baby had this? There's no way for them to know. And the vascular lesions that are picked up on prenatal ultrasonography rarely are vascular tumors like hemangiomas in the liver, but more often are going to be vascular malformations.
Well, thank you very much, Dr. Mancini. I know this is a very relevant topic to many of us, and I think what you shared with us today was very informative and very clear. So thank you for your time and for the information, and I hope you enjoyed coming on to the Derm Club podcast today.
Hannah, this was great. Thanks for taking the time, and I hope the listeners enjoy this.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.